It's with great honor that I commence today's academic proceedings with our first lineup. To chair the session, I invite Dr. T. Aravindan, Dr. Sanjay Marasinghe onto the stage. Topic of the session will be Case for Ultrasound Scan Training in Urology Residency. Over to you, sir, to introduce the speaker.
Good morning, everyone. Let me introduce the first speaker in the plenary, first plenary in the second day. He is Dr. Richard Mills, consultant urological uroradiologist, UCLH, United Kingdom. Over to you, sir, to present your lecture. Thanks.
Good morning, and thank you very much for inviting me here today. I'm Miles Walkton. I'm a consultant interventional radiologist, so I'm not a urologist based at UCH. And I was asked to talk to you about the case for ultrasound scanning training in urology residency. I guess I could just as easily stand up here and argue the case to not, but I wasn't given that choice. But let's see what we can come up with. So first of all, just to tell you, I have not discussed this with the Sri Lankan College of Radiologists, nor my own college, nor your college, nor BAUS. So these are purely my views and nothing official. So I don't think this is going to play, but I was just thinking about what do people think about radiologists, and this was just a video explaining how awkward radiologists could be blocking getting scans done. But I think this was a time when actually scans and everything were quite precious, and I think now with the advent of technology, things are becoming much more common and easy to do. As far as urology goes, there's always been a little bit of beef between the interventional radiologists and the endourologists who should perform, for example, the track for PCNLs. This paper here suggests that there is probably no difference, and I think that's probably right because this was a bunch of urologists that regularly did things, and I think that's really important. So the key question is, do I think urologists should learn ultrasound? Well, I'm not going to tell you what I think right at the moment, but let's go through it and see what we can come up with. So what we're actually talking about is something called point-of-care ultrasound, and there's been an explosion of this over the last few years. So what it is an ultrasound delivered by a person without the radiology department, i.e. not a radiologist, not a sonographer. And it's usually done at the bedside or in theatre. And why are we using it? It's because it's a very powerful diagnostic tool, and also it's very useful to guide procedures such as central lines. In A&E, they're using it to do the fast scan. It has also now become mandated to be used in certain procedures, which we'll come on to. The other important thing is the cost of machines is coming down. The original ultrasound machines are talking over £100,000. That's now come down to a few £1,000s. And also, within medicine, like within radiology, there has been a massive rise of subspecialization. So just an example, this is the first ever transrectal ultrasound. This poor man is sitting on a probe. And this is how it used to get done in a water bath, but we've come forward now, we've miniaturized things so you can do this laptop ultrasound, and you can even now put ultrasound on your phone. And this has all been guided by improvements in technology. What about subspecialization? Well, is subspecialization a good thing or a bad thing? I think more and more people are thinking it is a good thing. The idea of high volume centers, high volume surgeons improving our outcomes. So should we not apply that principle to ultrasound? Who is the best person to perform an ultrasound? Is it not a radiologist? Am I missing the point there? Probably. With increasing subspecialization, do urologists now have the time to learn their particular ultrasound that they want to do? And lastly, just a talking point, is there a role for a hybrid job incorporating imaging and urology? I do a lot of renal cryoablation. I sit in a urology clinic. I'm also a radiologist. So why do we want to do point-of-care ultrasound in urology? I think it's an excellent modality for a number of urological conditions because, for example, the penis, the testicle, the very superficial structures, they are imminently imageable with ultrasound. In fact, ultrasound is the best form of imaging for these, far better than MRI and CT. Imaging is used in a number of urological procedures. PCNL access, we've touched on, suprapubic catheter insertion. And as I said, there's an increasing subspecialization in urology. The other argument for point-of-care ultrasound in urology, obviously, is a lack of availability of radiologists. So I work at UCH, we're very lucky, we have dedicated pure uroradiologists, and we're able to go to theatre with our surgeons and have a good relationship. But quite often there may be a lack of radiologists, and I totally understand that ultrasounds need to be done. The other thing is out of hours, for example, priapisms. I'm a big fan of doing ultrasound for priapisms, but obviously, quite often they come in the middle of the night, so it's very helpful if the residents are able to do out-of-hours ultrasound. And then in places like the States, people are wanting more and more to do ultrasound because they get reimbursed for doing it. So you have to throw that into the mix as well. But this is from the Emergency Care Research Institute from 2020, where this is a list of the top 10 health technology hazards. And you can see there, number 2, adoption of point-of-care ultrasound. And this is the key thing, is outpacing the safeguards set in place. So what do I think the problems with point-of-care ultrasound are? First of all, with the operators. So quite often there's a lack of training, experience and skill. Machines, often, and this happens at UCH as well, ITU went off and they bought a whole load of machines, but they were pretty inappropriate for what they wanted. They're also, because they're not part of the radiology department, they're not connected to the PACS system. That means that any images done on them are not stored. Quite often people are not generating reports. All of this can lead to patients being adversely affected. Ultrasound is not easy. This is an ultrasound machine. This is actually getting a bit old now, but you can see the number of buttons and knobs on there, all of which you need to adjust to get an optimum picture. In the UK, I'm not putting in a radiologist here because we learn other things, but if you take someone that's just learning to use ultrasound, it takes them 3 years to qualify. The other great thing about ultrasound that I find is it's highly operator dependent. I take great pride in being able to do a good ultrasound. It is definitely a skill. And I don't know, many of you might sometimes turn your nose up at ultrasound done by someone you don't know. There are recommendations out there. This is from our British Society of Ultrasound and from our Royal College of Radiologists. But I'm not sure that anyone in the UK actually follows these guidelines because they're quite heavy. If you read through all of this, you have to appoint a lead who's responsible within urology for the ultrasound. Ensure a list of authorized users is maintained. I don't think any of this actually happens. And then, they recommend that people that use the machine understand what all these things within ultrasound actually do. Time gain compensation control. Does anyone actually know where on the machine is the time compensation control? It's actually there, it's really important. But saying that, I think technology will change this and there will no longer be these buttons and you will be able to just put the probe on and have a look. What about training for our urology trainees? This is a syllabus, I'm afraid it might be a bit outdated, but if you look down it, our trainees are expected to be able to do renal ultrasound, bladder ultrasound, scrotal ultrasound. I am not sure that they get adequate training in any of these things. So what is the solution to all of this? The honest answer is I don't know, but I think it's really important that as urologists you define the procedures that you want to do in collaboration with the radiologists. We must get adequate training and we must ensure that there's governance. And I think all ultrasound scans should have some form of report. Again, we can help you with the machines and what to purchase, and again, get them plugged into the IT support of the radiology department. And the message to radiologists, be available, come to theatre. And then if that's not possible, then we can't sit here and moan about people wanting to do ultrasound, because at the end of the day, it is a very powerful tool and needs to be used. So where do I think that it does play a role in urology? I think for kidneys, I think it'd be very useful for you guys to be able to pick up hydronephrosis. I think you're already doing PCNL access. Bladder, well, we've got bladder scanners, but now it's sort of mandated suprapubic placement. I do think it probably plays a role in priapism between the non-ischemic and the ischemics, possibly pushing up fractures, and in the testicles. But, you know, it is quite difficult to tell what's what. I'm not sure if you all know what that top right image is. It's actually an erect penis, and the bottom one is a testicle. So let's just go over a few examples. So this is a kidney. Here's the anatomy. Hopefully you all know that. That's what it looks like when you're actually scanning through it. So let's just take something simple like renal grading of hydronephrosis and picking up hydronephrosis. That's a fairly standard grading system, I think, on ultrasound. And this is here what it looks like. So first thing here, I don't know. I was hoping all the trainees would be in here, but I think they've all disappeared to be taught more important things. But for example, having shown you that, what grade of hydronephrosis do we think this is? 1, 2, 3? The answer is, of course, it's not hydronephrosis, it's a parapelvic cyst. So there are, of course, mimics of things that are important to know about. So this one, what grade of hydronephrosis is this? Well, I'm not going to trick you. Again, I think that's a grade 3, but the important thing is we put on the color box here so that you can see the arteries and the veins, and you can definitely see the dilated collecting system. So let's go for another one. What grade of hydronephrosis is this? Well, it looks very similar to the last one, so we're going to grade this at 3, except we know now to put the color box on, and actually it's just some prominent veins. So quite important to know how to use the machine properly. You don't want to be sticking needles into the arteries and veins. Guidance, you can cheat. I think quite often I've seen urologists use needle guides. Needle guides are really good. I guess it's a badge of honor thing, interventional radiologists. We turn our noses up at these things, but actually they're quite a good thing. But they do limit how you can place a needle. Obviously, new guidance has come out about the placement of suprapubic catheters, suggesting that they are placed using ultrasound. The only reason that they're used, of course, is to avoid bowel injury. Now, I grant you bowel injury, placing a suprapubic is fairly rare, about 2.5% risk, I think. However, if it does happen, it is quite catastrophic. So this is what the bladder looks like in a lady on the left and a male on the right. The problem is the reason we're using ultrasound is to try and identify bowel. And the problem with bowel on ultrasound is it can be really difficult to see. So just an example here, I've actually drawn around this thing to point it out, but you can see in red, that is the bowel interposed between the anterior abdominal wall and the pubic symphysis. It's much easier to see on a modality such as CT. So in conclusion, radiology training in residency is, well, the result's not ready, we'll wait for tomorrow. But with adequate training and in collaboration with the radiology department, I think it can only be a good thing. Thank you.
Thank you, Dr. Richard, for the excellent presentation, and we are highly appreciate your radiologist support in the urological care. And please come center of the stage to take the token of appreciation.